Good morning. So welcome to this session on hospital care. I would like to start by thanking our two discussants, Søren Kristensen from the University of Southern Denmark and the Imperial College, and Eliana Barrenho from the OECD. So you have already seen the videos of the papers and the presentations. So we're going to have half an hour. And we'll try to devote 8 minutes to each paper with first some academic questions. So Søren will start asking some questions and then I'll follow up. And then we'll next papers and the third paper. And then after that, we'll move to the policy part where Eliana will make some general remarks about the policy implications of the work and ask some specific questions. So the first paper that we have today, the causal effect of volume on health gains from hip replacement surgery, evidence from England, from Lake. So I'll now leave it to Søren to ask his questions on the paper. Thank you, Søren.
Okay, so thank you for the opportunity to read your really interesting work and to comment on it. that goes for all three papers, but now I will start on this first one on scale economics in the health sector. So first of all, I wanted to say that I think this is a really important topic. There's many countries that are moving in this direction at the moment, trying to centralize care, and so, as you say, there is a literature out there, clinical, finding a positive volume outcome relationship, and I think it's really nice to see some thorough econometric work that is trying to address this potential reverse causality. So I kind of congratulate you on that. I also have to say I really liked your use of prompts to address the question. I think that alone really makes it a contribution to the literature. I have a couple of comments, which are not questions, but is maybe suggestions for where you could focus your continued work on this, and then I will clearly indicate when I get to my question. So first of all, I thought it would be nice for you, when you continue working on this, if you could give us some sense of how many are there of these different types of volume hospitals. So you kind of group the hospitals into a sort of low volume, I think it's less than 300 cases, then there's a medium group and a high volume group. And for me, it would be nice to understand more about how many are there of these different groups. Maybe it's somewhere in the paper, but I didn't find it. So I think that could be nice to understand a bit more about. I think it would also be nice to maybe in your discussion talk about how your findings, where you find there is no positive volume outcome relationship, how can they be reconciled with this recent work from Germany that you cite, where they do find a relationship when they're looking at mortality. So it's another outcome, but I think it would be nice for you to make some reflections on that. So now I'll get to my question. And that is about your interpretation of the findings. So you don't find a volume outcome relationships when you're using the predicted volumes. This is your preferred volume model. And I think that is probably true in the way the data is set up now. But still, I wonder how far should we take this? Should we interpret this? Because I think intuitively you would imagine that for very low volume hospitals there could potentially still be an effect, and so I just wonder if how would you interpret these findings? Would you say that any small hospital can just go ahead and do a single surgery per year or a few surgeries per year, or would you say there is probably some lower limit, and can your data inform this lower limit? Can it tell us anything about that? So that's my first question.
Yes, so thank you, Søren. Thank you very much for the general comments and suggestions. And regarding your question on the very low volume, so it's true that it's one of the limitations of the paper that we're using English data, which is very nice. We have prompts which allow for very nice controls, but it's true that the hospital market in England is quite concentrated already. So that's probably a limit, and that might explain why in some countries they found different results. However, we're still able to observe quite a large range of volume, and we start from very low volume at around 20 cases a year. So that's the first way of maybe explaining the results. The second thing is that we are quite, we explain that we find this result in the context of planned hip replacement. So there might be some positive economies of scale in other contexts, in cardiac surgery. So in this case, in this paper, we've looked at planned hip replacement. So that there might be some other results for other surgeries, of course.
Okay, then I think I was allowed a second question because Luigi is a co-author. So if that's okay, I will go on with that now. I think a really nice feature of the data is that you have also have the individual consultants, or at least the consultant teams, which is something, if I compare to, for example, comparable data in Denmark, we don't have that. So I think it's something that really is a strength. And I wonder if you could do more with that. So, for example, would you be able to say something about what's kind of the optimal mix of team sizes, or is there something about learning effects you could be doing, or something about how many consultants is it good to have working together? Is it better that there are a few rather than just sole consultants? Something like that. Maybe you could do a bit more on that in the future.
Yes, I think it's a very interesting suggestion, and I think in the future this literature on learning curve might want to go to drill deeper into the mechanisms, also to inform the policy implications. In our context, we control for quite a large range of hospital characteristics, including personal staff, but we control it and make sure that we still have an effect at the hospital level. And the reason why we focused at the hospital level and static scale economies in this context is, again, because for planned hip replacement, what we might expect, the positive effect might be more at the hospital level, because it's a procedure for which is quite an important perioperative care, rehabilitation, follow-up surgery, etc. So in this context of this surgery, it makes sense to look more at the hospital level.
Thank you.
Yeah, thanks, Søren, for the questions. So I think we still have a couple of minutes, so I'll also ask one question. So my question is about the way you define volume. So at the moment, I think you define the volume for hip replacement, but we know that the doctors, they do hip replacement, but they also do all sorts of other procedures. And if they do more in other procedures, maybe this helps them becoming better for hip replacement. So can you think how you could address that point?
Yes, thank you. That's a very good question. So it's in the next steps of the paper where we will try to measure hospital volumes and consultant volumes a bit differently by first find some example, including emergency hip fracture care, which is a related procedure, but a different type of patients, and of course emergency. So there's less preparation and team effect that might go into it. And we might also include the elective knee replacement, which also is related, is an orthopedic procedure, but not exactly the same as hip replacement. So it would be interesting to see what's the effect of that.
Okay, so thank you, Laurie. So I think we have covered the first paper, so we can move to the second one. So the second presentation was by Angela Meggiolaro on comparing quality of care across healthcare systems. So again, we can follow the same format with starting Søren with one or two questions you can choose, and then I can come after.
Okay, yeah, so thank you. I also found this this paper interesting, especially given this really increase we have in information and performance indicators. There was a paper some years ago counting performance indicators for the US Medicare, and I think they found several hundreds. So of course it becomes a question, how can we digest this all this performance information? What's the right way to use it and get the most out of that? So I think it's an important topic. If I think about maybe a suggestion for what you could do when you continue your work on this, I think it would be nice to spell out a bit more clearly how your approach is different and how it is an advantage on the work that has already been done on composite indicators. There are some studies, there's like McLellan and Steiger, I know Irene Papanikolaou and McGuire did some work, and there's some other work from Samuel and colleagues that have tried to come up with ways of combining performance indicators. So I think would be nice to see you spelling out more clearly what is it that you're doing different. But that's my question is more of a comment in terms of how you present it. So my question is not so much on the technical detail, but perhaps more about the implications of your work. So you're putting some time here in the paper discussing competition and how the need to facilitate competition can be supported by your work, because you can, patients can use this composite indicators when they're choosing a hospital. And so maybe my question is a bit tricky, but I'm wondering whether for an individual patient who's going to have a particular type of surgery, say knee surgery, hip replacement, do you feel that the value of having a composite indicator is greater or lesser than actually knowing the quality for the individual condition that you are going to be treated for? I think maybe for individual patients, the performance information on the individual indicators are important. And I think maybe what you could think more about is the regulatory perspective. This is where I see the value of having this more broad indicator of performance. So I don't know if you have any reflections on that, but it's kind of a bit of a broad question maybe.
Thank you for your question. I hope you can hear me. Yeah, so definitely I don't want to go through the technical advantages of a composite index. Of course, previous works prompt our research. Basically, we gave with this model the granularity, so we don't impose an endpoint in observing patients. And like administrative data, we don't have prompts, right? We don't have patient level data or surveys. So administrative data are used overall in all OECD countries, and low cost probably, and are also reliable. So that's one, the main advantage. But mostly they allow us to follow up patients for all the sectors and subsectors of healthcare. And we, in Germany at least, they are really reliable. For the use and the application of this index, and for the effect on competition, the empirical work it's still ambiguous about the fostering quality, the foster quality, and the relationship between competition and quality, of course. But we followed the main work. It was McClellan that prompted our research. So we followed that line, that competition actually can improve quality of care. So the application is both at policy level and regulatory level. We, of course, policymakers didn't do a right use of composite index, because they are not so easy to understand and not so easy and not so reliable. So we thought we gave with this index, I don't know, a contribute to understand and to basically apply easily apply an evaluation of quality at policy level, either on competitive markets or not perfect markets, like what's happening in Europe. And that's it. Yes, regarding patient choice, now at policy level, different states are more open to leave patient choice. So they are opening to patient choice healthcare in general. So we recommend that with this contribute at policy level or regulatory level, maybe patients can be informed better then other factors or other agents like doctors suggesting an hospital, and other factors that you perfectly know, and factors that have been already studied in the literature.
Thanks, Angela. Sorry, do you have another question? Or?
I have a little, just a small follow-up question, maybe to kind of demonstrate the benefit of this combined index or composite indicator. Have you tried doing the rankings sort of with for individual conditions independently, and then see how much does the ranking actually differ when you do the combination? It's about the correlation between the quality across the different indicators, I guess.
Yes, I've tried. Actually, we considered readmissions only because mortality is still a rare event. So with readmission, I got the same result, exactly the same results. And I also compared only in readmission 2 countries, and I saw the differences that I personally attributed to different aspects of the hospital markets. I've compared Germany and Italy only on readmissions, and actually I saw the difference. The Germany index was basically the same. There was still a difference between top and bottom performance, standard performance, but conversely in Italy I found only standard performers in readmissions. So yeah, I've tried, and the index is also reliable. That's because we use weights, and we weighted each outcome, so each readmission and each mortality event times, so for each cardiovascular events. So each one has a weight, so each one has a position in the rank.
Thank you, Angela. So okay, I also have a couple of follow-up questions, and I think they are related to Soren questions. So the first question was in relation to how to interpret the indicators, and whether these were more trying to inform patient choice, or whether we should think these more as a performance assessment. So this relates, I think, to how you use in your analysis the hospital characteristics. So in my mind, what I was thinking is that, well, if you're a patient, you know, whether you are a teaching hospital or not, what I really care is just like the quality of care that I get. So in that sense, you don't need to control for those hospital characteristics, because what matters for me is just if the mortality rate is high or low, regardless of the type of hospital. Instead, if you're doing like more like a performance assessment exercise, then actually that's where you want to condition of hospital characteristics which are outside of the control of the hospital. So if you're a teaching hospital or not, then that's fixed, or if you are for profit or profit, that's outside of your control. So I guess, again, my question would be, do you think your analysis more as informing patient choice, or is it more like a performance assessment? So I think, or maybe both, but that was my question. I also had a question about the composite indicators, in the sense that I think you have already replied, but I also wondered that if you are suggesting like a quite complicated and advanced methodology, which you know, only a few people can replicate, it may be valuable to compare with the simple indicators, so that policymakers can check, you know, is it very different or is it very similar? So yeah, so maybe you have already covered some of this, but if you have any last words on this.
So regarding the first question, of course, I specified in my chapter that this index first off is a big picture of hospital performance. Also, we've been working on a small sample. It's 10% of German cases, right? Of German cases, yes, because we used data from one insurance company. So, and it's not the biggest. That's one question. And the second is, yes, we mostly aim to measure performance from a policy perspective. And then we assume that the patient that makes choice is rational, right? So in the last, what I can say is that after, yes, the validation of this index and the release, the dissemination of results, maybe patients can be more informed, because what we know is that there are other factors influencing patients' choices. That's the physician, basically. And, you know, at least in systems like Germany or especially Italy. And regarding the second question on controlling, yeah, I think that's that we control for hospital factors that cannot be under hospital control, of course. And the advantage, as I proved in the second paper, trying only readmission, I'm doing that with the Italian, by comparing Italian and the Italian and the German sample. Yeah, we are using just readmission. Also because in Italy, we don't have data on mortality. So we are using just readmission, and we are actually having the same results.
Okay, thank you. Yeah, I think we can now move to the third paper. So thanks for those questions and the answers. So the third paper, final paper, is by Sabat on hospital financial performance and quality of care evidence from Portugal. So again, over to Soren to ask questions.
Yeah. So again, I think really important topic here. Both, I mean, it's not so often I come across papers looking at this financial performance, but I think it's really interesting. What's the impact on quality, and of course, understanding the impact of the troika in particular, I think is really important. Also, you know, who knows what new policies are coming now? These in the follow-up to all the COVID challenges. So I think really interesting and important topic. I also really like that you're using patient safety indicators. So these PSIs, you know, we often focus on mortality and readmissions, but maybe they are too crude sometimes. So it's nice to see also a broader range of quality indicators. I like that a lot. I think when you continue working on it, for me, it would be nice to understand a bit better what do you think the mechanisms that could be driving these relationship between financial performance and quality is. You know, you make some kind of some statements about what was the impact of the troika, for example, on hospital finances, but I would like you to see, maybe spell out a bit more, how do you think it affects quality? So is it about, you know, the best staff is seeking to another hospital? Are they kind of moving away from the financially poor performing hospitals, or even maybe going abroad? Or do you think it's about the resources available for the actual care? So maybe some thinking on that, I think could be nice to see. Now, my question is about how you can distinguish this thing, which I think is a correlation you find between poor financial performance and poor quality from poor management. Because maybe it is the case that if a hospital is poorly run, that is true across multiple dimensions of that hospital. So, you know, if you have a poor management who can't really steer the financial performance, maybe that also just means that it's a bit loose on how it manages clinical performance. So I invite you to think about, how can you disentangle this relationship? How do we know it's not just you know, a third factor, namely poor management, that's driving this?
Thank you, Soren. Very valuable comments. Thank you, yeah, for overall comment. So to say about the first one, I think I focus mostly on the resources available for actual care. So this is the mechanism, how it works. Yeah, and about this, I agree. This is rather a correlative relationship between quality and financial performance. But what we do, we basically say that financial performance is a proxy for managerial performance. So this is how we judge the management. Because in case of public hospitals, being financially performing well financially is not of first order importance, right? So so we basically judge managerial performance. Yeah.
Okay, thank you. Yeah, I have maybe a follow-up
Sure.
suggestion, which is about your second aim is about looking at the impact of the troika, and yeah, I didn't completely understand how you use what the troika is doing to try to identify this impact, but I think I feel that there must be something you can do there. So can you maybe look at hospitals that were kind of pushed into poorer financial performance after the troika, and then you can compare to those that kind of were exposed to the troika, but they managed to stay clear? I don't know if that could, if you can kind of use the variation that the troika imposes in financial performance, maybe. Would that be possible?
Thank you. That makes complete sense, indeed. And maybe, so my problem was that I had data available only for until 2017 full year, and troika agreement ended at the end of 2014, so there wasn't much data available after that. And in Portugal, they have around 50 public hospitals, so it's not much. But I think that now I can request more data and maybe try this methodology. That would be really interesting. Thank you.
Thank you, Soren, for the questions, and Irina for the answers. So I'll move to my set of questions. So I'll start with one which is similar to Soren, because I was also thinking about third factors that could affect both quality and performance simultaneously. And the example that came to my mind more like related to recessions or like economic downturn. Well, if the effect is the same across hospitals, then I don't think you have a problem. But if this is differential across hospitals, so that each hospital is affected in a differential way, well, that could be a mechanism that is behind your results. So again, it depends if you're trying to write these results as causal or as association type of results, in which case then that becomes like a mechanism. The other possibility would be to control for that. So if you would have variables that are related to the economy at the more local level, so that it varies, so that you can attribute at some level to the hospital through the catchment area, or maybe like the general funding at the local authority level. That could be like a way to try to control those sort of shocks. So that was my comment that about this third factor. The other, I had a couple of other questions that relate more to the analysis and interpretation of the results. I mean, you emphasize that you have reasonably heterogeneous results across indicators, and I also like the safety indicators. But some of the coefficients that you find for the safety indicators, they look very, very small. So in that sense, I don't know if you could have a feeling of how important they are, in the sense that they are statistically significant, but should we think them as quite important economically or not so much? I'll pause there in case you like.
Yeah, thank you. I thought about that. I haven't yet implemented that, but I already got that suggestion that, yeah, so especially for policy implications, we need to show what exactly impact could be, because these small numbers don't say much. But they are comparable with the numbers, so the magnitude is more or less comparable with those previous studies that were conducted in the US. So effect is really small, but I agree that it needs to be translated into words or real impact. Thanks.
Yeah, I had a question also about the partial adjustment model. In the sense, I think that's a nice feature of the model, that you can see how quality is persistent across over time. So could you comment on that coefficient? So if you think about lagged quality, shall we think that there is lots of persistence in quality, or if it's like a low value, then the quality changes quite quickly? And related to that, I think you do this comparison when you do the partial adjustment or not. So in that sense, the question is like, how important is this correction for partial adjustments?
Thank you, Luigi. Yeah, so it's difficult to answer because I check around 30 indicators and results are a little bit different. So they are diagnosis or indicator specific. So in general, this partial adjustment mechanism lets me account for this lag between the impact of the financial situation and quality. And well, if I write the model for this partial adjustment mechanism, that we can see that 1 minus this theta adjustment coefficient is actually how fast the impact shows itself. So in simple words, we can say that how quickly people get hurt. So when I checked that for the quality indicators, so for the in-hospital 30-day mortality, we saw that the quality between periods T and T plus 1, so quality between two periods, it absorbs it absorbs only part, so the effect lasts longer. But if you look at patient safety indicators, the situation is opposite. So on that side, people get hurt faster. So almost all impact from the financial side translates very fast into the patient safety indicator. And yeah, that was the finding that we identified. Patient safety indicators show faster the impact of the financial situation.
Okay, thank you. Yeah, I think we have covered the first part of the session. So we went through the questions. So I think we can move to the second part. So Eliana, like to come in with some general remarks. Then I think you could ask if you have the questions on the paper, you could ask them all in one go, and then we let. Thank you.
Thank you, Luigi. Thanks a lot for this opportunity to be here today and listen this very interesting session on hospital care. Congratulations to Laurie and Angela and Irina for this super interesting research. I really think your research can make significant contributions to the policy debate at the moment. I will make a general question to the three of you, and then I will also list to each one of you a question I thought about regarding your specific research papers. So at the moment, OECD countries are really struggling to make decisions around resource allocation between hospital and primary care, either reducing spending on hospitals and or actually transferring money to primary care or to outpatient specialist care. This is because there has been, you know, a general argument for for the increasing burden of disease on chronic conditions, aging population. Maybe it's better to actually locate resources nearby communities and outside the hospital. Now, COVID-19 is really putting pressure on this debate. And at the moment, I have no idea how this will play out, but there are definitely questions around whether hospitals are efficient places to treat patients. So my general question for you, I know it's not necessarily an easy one, but maybe it's also to give you motivation to pursue your research, is how do you think your research can inform this debate? How can you, at the moment in your analysis, how can you account for the fact that variation in hospital performance and hospital care quality may be or not impacted by quality of care outside the hospital? So this is my general question for you, which I think if you could at some point in your analysis of robustness checks consider, I think it would really help the current policy debate around this topic. And it could inform how allocation of resources can be actually better done. Now I'll go to Laurie. Thanks so much for this paper on scale economies on quality outcomes. This is indeed a very important policy topic. Policies to concentrate in patient care continue to be challenged in several OECD countries, provided the unintended consequences on quality and access to care. And this is particularly true in countries with large countries and heavily dense. That's the case, for instance, of Sweden, which I know the debate is at the moment, very hot regarding this topic. I also like the fact that you are very well placed to use linked administrative data to PROMs. This is definitely you know more than me that that English data is very well placed to make a very big contribution in this area. Many other OECD countries cannot actually have or access very easily to this data. My question to you is, Laurie, how sensitive is your analysis to this self-reported outcome variable? Do you think your results would change with all the measures of quality of care that are standardly used in this setting? For instance, how do your results compare if you look, for instance, for the proportion of patients that receive surgery within 2 days, which is what is clinically advisable, waiting times, or even, you know, reoperation, the risk of a reoperation? So that's my question to you. Angela, thanks for also bringing this very interesting work, comparing quality across healthcare systems is definitely a challenging one, and continues to be challenged by methodological aspects. Also provided, as you know, the several factors that might be impacting that measurement. Not only there are a very big increasing number of indicators that are used to rank countries and compare countries, but also health systems are in an essence different. They are not necessarily easily to compare. And that means that health information systems are not necessarily recording the same type of data, and they don't necessarily have the same quality. So I thank you for, you know, trying to address this part of these challenges with your composite index. My question to you is, though, how do you think variation in the data quality between countries can actually affect these comparisons on quality of care? In particularly, for the case of Germany, how do you think that insurance claims data is appropriate to make inferences about quality of care? Is this data recording absence of care delivery, well as other administrative data sets, mortality, or even comorbidities? So it's more a question regarding the nature of the data and whether you are missing some dimensions of quality of care. And finally, to Irina, thanks for this huge analysis on hospital financial performance and quality of care and evidence from Portugal. The effects of austerity on quality of healthcare and access to care continue under scrutiny. I'm sure you follow the news, and these days the public opinion and medical community, for instance, in France, is arguing that the financial decisions taken in the last decade have caused so much strain in the hospitals, in the hospital capacity and their workforce, that they are at the moment unable to cope with the current crisis. So they are basically blaming previous decisions, austerity measures, that affected directly hospital capacity on the current situation. It is scary to learn from your paper that actually the financial pressure we felt in Portugal can actually drive so much unsafe care within the hospital. So my question to you, Irina, is to what extent do you think cost containment policies targeting hospitals are preventing patients to be treated within the hospital, passing the burden to the outpatient care setting? Can you find, would you be able with your research to try to find unintended effects of austerity on the one hand, access to inpatient care, and on the other hand, a crowd out effect, for instance, on outpatient care? So these are my questions, and happy to hear from you.
Thank you, Eliana, for these important and challenging questions. I think they're great questions. So I think we can go in turns. So we can start with
Yes, thank you very much, Eliana. It's indeed very interesting. I think what you say about understanding better how to best organize the hospital care market is very important. And I think we were trying to address that question a bit. And I think what you say about probably trying to move away from a hospital-centric model to a better integrated care would be very important. I cannot reply to that very well. I'll just try to address your point about how we can adjust, can control when we measure the variation in hospital quality, how we can control for differences in the quality of the primary care around the hospital. So what we do in this paper, we account for that a little bit by controlling for some key characteristics in the catchment area around the hospital, so in 30 kilometers around the hospital, and we control for the mean distance to the GP, which is a way of capturing differences in access to primary care. So it's not perfect, it's not exactly answering the question, but that's a first maybe way of getting at it. And your second question was, so how sensitive the analysis is to the use of self-reported measure of quality. I think what is interesting with using the prompts, as you, I think all of you mentioned, is that we are able to have a more fine estimation of quality, more than using some failure outcome, which would be really yes, no. Here we're trying to get at something a bit more precise because we're using a planned procedure, which is very common, and we're trying to get more at how the pain is managed, etc. So this is why we didn't use mortality, because mortality is very low. You mentioned using the percentage of surgery which took place within 2 days. I think that's an outcome indicator for emergency hip fracture, so not so much for planned hip replacement. But we did some robustness check, but it was not in the paper that we circulated, using revision rates, using the proportion of hip implants that were revised within 1 year, and we find a similar results. So this, which existed, our measure of outcomes is robust to other choices of outcome.
Thank you, Lori. So, we can move now to Angela. Angela, would you like to answer the questions about the performance assessment?
Okay, thank you for your questions. So about the data reliability, previous studies have already showed that the insurance claims or insurance patient level data are highly reliable. I think that the 85% of the hospital reimbursement in Germany is made by the insurance companies, public insurance companies. So the Schreier and Stargard already showed that the data are reliable. Of course, other studies supported this hypothesis in the sense that other studies showed that the differences in outcomes by using records, clinical records, and administrative data are not significant. So it's basically the same. Of course, we cannot capture all the patient's level comorbidities or the patient level socioeconomical status variables. That will be possible, but we use a failure rich model. We use the two the Elixhauser and the Ontario myocardial infarction, for example, risk adjustment for the case mix. We also adjusted for socioeconomic status by linking with other databases, and the same we did in Italy. So under this point of view, I think that the index is very robust. Also, the advantage is that administrative data, and then I want to link with the question about the COVID-19, is that we can follow up the patient in hospital and outside the hospital. The COVID problem was a public health concern, okay? So here in Italy, for example, we had a great differences between two regions. One, Lombardy, where the hospital, it's hospital centered, and Veneto, which is public health centered. And we saw the differences. Veneto can lift before the lockdown, control better the pandemic because it has a strong public health system rather than an hospital-centered systems. So, I mean, this is what the answer also to my question. What we cannot see is of course, the condition of the patient is time varying, right? So the condition can deteriorate over time, even in hospital. So of course, the clinical records are more precise than administrative data, but still we can control for the main for the main comorbidities. So it's definitely reliable and robust.
Thank you, Angela. So then the last question is for Ina.
Yeah, thank you for the question, Eliana. This is not an easy one, and I'm not sure I can answer it completely, but yeah, I can try with what I've already done in my research. So whether about these unintended consequences, I believe that it can happen indeed, that the crowd out effect may occur. So how I would based on what I found out in the research, is that the special attention should be paid to hospitals that are poor performance, and especially when these cost containment measures are taken there, because these poorly performing hospitals, assumingly they have worse management, and then they may have it difficult to find some other investment options, or in any case, any investment opportunities to increase quality of care. And my research, basically, the methodology compares hospital with respect to other hospitals. So if the gap continues to rise between these poor performers and better performers, then the population of Portugal may have may receive different standards of care. And so I believe that at least from the demand side, indeed, there could be these choices that people choose not to go to certain hospitals. And also that could be pressure on GPs. So I believe in 2017 in Portugal, patients were allowed to choose the hospital where they want to go, not necessarily go to the hospital in their catchment area. So this may also trigger the fact that patients may put pressure on GPs to be referred to a certain hospital, and then the allocation of resources on the national level could be also inefficient. So I cannot answer about the outpatient services, but I could see the problems even within the hospital system. So I assume that your link makes sense, and that would be interesting to check indeed. Thank you.
Yeah, thank you, Ina. Just going back to the question about from Eliana, the first questions about how COVID impacted the hospital care and the relationship to specialist services and primary care. Well, I think what we can expect is that the interface between these different elements, these different subsectors, has changed, and probably will have to change quite quickly, because perhaps if you think about primary care potentially could play a very important role in making sure that there is like a prioritization of the cases when they arrive at the hospitals are the right cases. I'm not sure every country has made sure that primary care would as much as possible, but probably, you know, in some countries primary care felt a bit put on the side. So I think this is really a time where we can rethink and redesign services, and this is urgent, so this cannot be. So let me conclude. We have run out a bit over time, but this was an excellent session. So I would like to conclude by thanking Soren and Eliana for taking time from their busy schedule and reading the papers and making all these interesting questions and comments, which I'm sure will be very useful for the PhD students further advance their research, but also to make sure that that we understand how the research feeds into the policy context. Okay, so this concludes this session. Thanks again, and see you soon. Bye.
Thank you. Bye.
Thank you.